Continuing our discussion on pleural effusion, let us see the diagnostic algorithm. So if a patient of pleural effusion, first we need to do a diagnostic thoracocentesis. And then we'll measure the pleural fluid protein and LDH. If the pleural fluid upon serum protein level is more than 0.5, or pleural fluid LDH upon serum LDH is more than 0.6, or pleural fluid LDH is more than 2/3 of the upper limit of the serum, of the normal value of the serum LDH, and these are the lights criteria. If any one of them is present, then it is an exudative pleural effusion. If not, then it's a transudative pleural effusion. In case of exudative pleural effusion, we need to see the glucose level, the cytology, the DLC, the culture staining, TB markers. If the glucose is less than 60, then it could be because of malignancy, could be bacterial infection, or could be rheumatoid pleuritis. Now, if none of this, no diagnosis could be made. So if no diagnosis is made out of all of these things, then we can consider pulmonary embolism and we can go for spiral CT or a lung VP scan. If it shows pulmonary embolism, we can go for treatment. If not, then we can go for the marker for tuberculosis. If they are found, then we can go for treatment for pulmonary tuberculosis. If not, then we'll see whether symptoms are improving or not. If symptoms are improving, then we can observe. If they are not improving, then the last option is pleural biopsy. We can go for thoracoscopic or image-guided pleural biopsy. Okay, so this is the diagnostic algorithm for pleural effusion. First is we need to do the thoracocentesis, and then we have to see whether it is an exudative or a transudative pleural effusion. In exudative, we have to see the glucose value. If glucose, then we have malignancy, bacterial infection, or rheumatoid. If no diagnosis could be made, we can suspect as pulmonary embolism. If that is also not, then we can suspect tuberculosis. If that is also not there, then we can go for pleural biopsy. Now, how we'll manage the underlying cause. Then drainage if it is symptomatic, and we slowly drains. If rapidly drainage is done, then it can lead to pulmonary edema. Why? Because of rapid inflation of the lung after prolonged collapse. Now, chest tube drainage could be done if there is a repeated effusion and that is happening very rapidly. Then for malignant effusions and for recurrent effusions, we can also go for pleurodesis. Pleurodesis can be done using tetracycline, bleomycin, or TARC. Now, drainage, the pleurocentesis is usually done in the 7th intercostal space in the mid-axillary line. Now, we talk about parapneumonic effusion. It's the most common cause of exudative pleural effusion is parapneumonic effusion. And the most common cause of massive exudative pleural effusion is tubercular effusion. The parapneumonic effusion is associated with bacterial pneumonias or lung abscess or a bronchiectasis. Okay. Now, if it is an aerobic infection, it is usually an acute presentation, an acute febrile illness with chest pains, sputum production, leukocytosis. If it is an anaerobic infection, they present as a subacute illness with weight loss, brisk leukocytosis, a little bit anemia, and there is some predisposing factors leading to aspiration. Okay. And investigation, chest X-ray, CT, ultrasound, chest. If fluid level is more than 10 millimeter in a lateral decubitus film on a chest X-ray, then we go for therapeutic thoracocentesis. Now, what is the indication for tube thoracotomy? There is a mnemonic LP-GOP. If flocculation is present, the pH in the pleural fluid is less than 7.2, glucose level is less than 60, organism is found on gram stain or culture, or pus is present, or gross pus is present. Okay, then we can go for intrapleural thrombolysis also, and this is done when loculation is present but there is no pus. We can use streptokinase or urokinase within the 3 days of effusion before fibrosis set in. So the thrombolysis is usually done early before the fibrosis sets in. Now, if the pus is present, then we have to see whether a single loculus of pus is present or multiple loculi are present. If single loculus is present, we can go for chest tube drainage under ultrasound guidance. If multiple loculi are present, then we will go for decortication. Decortication means stripping off the thickened visceral peritoneum. Thickened visceral pleura. Now, we can also go for thoracoscopy with adhesiolysis. Okay, so this is all about this. Thank you.